So hello friends, welcome to my new video. So today's topic for discussion is on optic neuritis. So let's start. So optic neuritis happen when there is an inflammation of the optic nerve. The pathogenesis of optic neuritis is still quite unknown, but it is likely due to some inflammatory reaction due to type 4 hypersensitivity reaction, which is due to secretion of cytokinin and due to activated T cell which cross the blood-brain barrier and cause destruction to the myelin sheath, and that is leading to axonal degeneration. In this slide you can see two fundus photo. Here you need to focus on the disc here. So here you can see the cup and disc ratio is quite zero point 0.5, and here neuroretinal rim is also normal. But if you compare this optic disc with this one, then it is abnormal. Here it is not clear, the cup disc ratio is not clear, as well as the disc margin is also edematous. That is optic neuritis. So these are the causes of optic neuritis, where there is different types of causes. Like it can be due to demyelinating disorders like multiple sclerosis, neuromyelitis optica, or myelin oligodendrocyte glycoprotein disorder, or it can be due to any infection like herpes zoster, measles, toxoplasma, tuberculosis, mumps, etc. It can be due to any inflammatory disorder like sinusitis also, or post vaccination can also lead to optic neuritis like hepatitis B vaccination, etc. Or age is one of the more big factor. Like here it is mostly seen in people who are around 20 to 40 years, where it is mostly seen that women are more affected than males. Okay, so if I talk about the multiple sclerosis, it is the inflammation of the optic nerve of brain and optic nerve inflammation both. So there is multiple sclerosis. So neuromyelitis optica and myelin oligodendrocyte glycoprotein, these two disorders are more severe than multiple sclerosis. Where neuromyelitis optica, it is the inflammation of the optic nerve and spinal cord, and it is more severe than multiple sclerosis. If I talk about the myelin oligodendrocyte glycoprotein disorder, it is the inflammation of the optic disc, spinal cord, and brain neurons. So this is also quite more severe. Now, optic neuritis vision loss due to neuromyelitis optica and myelin oligodendrocyte glycoprotein is more severe and result in larger type of scotoma. So these two disorder affect optic nerve, optic chiasma, optic tract. So bilateral vision loss is very common. And remember this thing: once the optic nerve get damaged, it will not regenerate or recover. Okay, so the damage is very permanent. Now, neuromyelitis optica lead to severe vision loss with poor outcome. So this disorder also lead to degeneration of the myelin sheath of spinal cord neuron, leading to restricted physical activity of the person. But myelin oligodendrocyte glycoprotein is less common than neuromyelitis optica. Okay. Now let's go to the types of optic neuritis. So ophthalmoscopically, optic neuritis is three types: retrobulbar neuritis, papillitis, and neuroretinitis. So this is retrobulbar neuritis. So retrobulbar neuritis, in this type of optic neuritis, retina appear normal with normal optic disc, but the inflammation actually happen behind the optic disc. Okay, so this is retrobulbar neuritis. So in retrobulbar neuritis, the optic nerve fiber get inflamed due to defective signaling, and due to inflammation of the optic nerve fiber, it lead to defective signaling to the brain, leading to impaired vision in the affected eye. So what are the signs of this retrobulbar neuritis? So it is leading to dimness of vision, blind spot in center of vision, color deficiency, pain while moving the eye. Because why pain? Because the inflammation happen behind the optic disc in the intraorbital part of the optic nerve. So here you remember what is the origin of extraocular muscle? That is the annulus of Zinn or common tendinous ring. So that is around the optic nerve here. So if that part is inflamed, that the inflammation also going to the annulus of Zinn. So that's why whenever the patient moves his eye in different gazes, it is leading to some kind of pain. So that's why this retrobulbar neuritis patient, mostly they will say that we are having pain whenever we move our eye from in different gazes. So that can be one sign. Another thing, severe vision loss in the affected eye. If I move to the papillitis, so papillitis where the optic nerve head is only affected, so it is mostly seen in children. Okay, Now let's move to neuroretinitis. So in this type, where there is swelling of the optic nerve along with presence of hard exudate around the macula. So neuroretinitis will have classic triad, and that triad is vision loss, disc swelling with macular exudates. So this neuroretinitis can be due to different disorders like Lyme disease, syphilis, tuberculosis, HSV infection, rubella, hepatitis, toxoplasma, etc. This thing can lead to neuroretinitis. But remember, retrobulbar neuritis and papillitis are normally associated with multiple sclerosis, but neuroretinitis always associate with inflammatory reaction. So these are the clinical features of the patient. So here the patient will say reduced visual acuity, pain while moving the eye in different gaze, reduced color vision, and reduced depth perception. Okay. So if I tell about the sign, then decreased visual acuity, presence of RAPD or relative afferent pupillary defect, abnormal color vision, changes in optic disc, presence of sectoral field defect or scotoma. Okay. So here, what this is showing, just see the reaction of the pupil, what you understand. So here you can see that the patient right eye is constricting, right? It is having normal constriction, but when the light is shown on the left eye, then instead of constricting, it is dilating because of the presence of RAPT. So there is four grade of RAPT, right? RAPT grade 1, 2, 3, 4. So mostly in case of optic neuritis, you will get RAPT 3, grade 3 or grade 4, where there is less constriction, greater redilation you will see. So this is shown in this slide. Now, these are the workup protocol for optic neuritis. So first of all, you need to take a proper history to the patient. Ask about any previous infection, previous any fever, presence of any neurological disorder, or presence of HSV infection, anything, trauma, anything, just ask to the patient properly. Or anything he taken any steroid medication, just ask what happened with him. And after that, measure the visual acuity. In case of optic neuritis, mostly the vision is limited to reduced vision to light perception. So that's why taking a proper visual acuity or measurement of proper visual acuity is very important. Visual acuity, refraction, and find out what is the best corrected visual acuity for the patient, and then check RAPD. Don't forget to check RAPD in case of suspected optic neuritis patient, because RAPD is very much important factor for all those people, because you need to examine the pupillary pathway. I taught you in my last videos where I was discussing on the pupillary pathway, the afferent and efferent pathway, how it is working, and there is also video available for RAPD. Just go and check the video. So measure the RAPD, and what is the grade? It is grade 3 or grade 4, grade 2 and 1. So mostly most students get confused in grade 1 or 2. So that's why check RAPD properly. Then go for color vision, because optic neuritis patient lead to color deficiency. So that's why checking of color vision is very mandatory. Even do prefer to check color vision in every fresh patient, whether he is colored blind or not. How you will understand? By doing color vision. So you need to measure the color vision by using Ishihara plates, right? After that, do a proper slit lamp examination to rule out any type of anterior eye segment abnormality. Then do measure the intraocular pressure to rule out any risk for glaucoma, right? Then do check the extraocular motility of the patient. In between them, after measuring the visual acuity, also prefer to check the contrast sensitivity by pallidopsin, because mostly optic neuritis patients have less contrast sensitivity than normal people. So that's why this is also one of the important tests that you need to prefer. After that, check for extraocular motility, because in case of retrobulbar neuritis, what I told or what I taught you, that whenever the patient moving their eye from in different gazes, up, down, right, left, it is leading to pain because of the inflammation of the optic nerve, leading to inflammation of the annulus of Zinn, that is leading to pain whenever the patient moves their eye, right? So that's why. So from the annulus of Zinn, four muscles get originate: superior, inferior, medial, and lateral rectus muscle. Right. After that, do a proper fundus examination and disc evaluation is very much important in this type of patient. After that, send the patient for MRI to rule out whether it is due to multiple sclerosis or it can be due to neuromyelitis optica or myelin oligodendrocyte glycoprotein. By doing MRI, you will get to know that. After that, send the patient for visual evoked potential. Okay. Now these are the investigation that you need to send for the patient, like brain MRI, blood test, OCT, YOCT to see what is the thickness for RNFL, and then do send the patient for visual field and also prefer VEP. So in case of visual field, you need to send 30 days to the patient. Okay. And also, whenever the patient is actually complaining of a black spot in front of their eye, ask them that whether the black spot is moving or still. If it is moving, it can be a floater. Who knows that? But if the patient say it is very much still, then do prefer Amsler grid test to that patient. I am also having one video on Amsler grid test. Do check the video so that you will know what is the proper procedure to do Amsler grid test. So that's why in every patient who say that there is a black spot and lines are in a distorted manner, images are distorted, just check Amsler grid. Okay. So these are the investigations. And if I tell you about the management, in case of optic neuritis, we give intravenous methylprednisolone 500 to 1000 mg once daily for 3 days and followed by oral prednisolone for 11 to 2 weeks. Okay, so that is our treatment. And it is seen that during a research, intravenous IVMP injections are more working and visual recovery is very much good in case of optic neuritis patient if it treated in proper time. Thank you so much for your kind listening.